Welcome dear students. In the assessment of hearing, after learning about the clinical methods of assessment of hearing, out of which the most important was tuning fork tests, let us move on to the next method, that is audiometric tests. We have various investigations that are done under audiometry, out of which the most commonly performed one is pure tone audiometry. Let us learn about pure tone audiometry in this video. So, pure tone audiometry is a non-invasive subjective test. Subjective in the sense you need the patient to respond to you and cooperate. And the results are based on the subject who takes the tests, based on the patient. It is a non-invasive and subjective test. So, what exactly is pure tone audiometry? In pure tone audiometry, there is a machine called as audiometer. It is an electronic device that generates pure tones. What are pure tones? Single frequency sounds. Now, normally the sounds that are produced are complex sounds. They contain various frequencies. Now, my speech modulation is in such a way that sometimes it is low pitch and sometimes it is in high pitch. The frequency is varying and even the intensity of sound is varying. But an audiometer produces sounds of pure tones. You can select the tone. Tone means frequency measured in hertz. So if I select 512 hertz, it will produce sounds only of 512 hertz at various intensities. If I select 1000 hertz, it will produce sounds only of 1000 hertz. So single frequency sounds are called as pure tones. So in pure tone audiometry, we use an electronic device called as audiometer. So audiometer is an electronic device that produces pure tones, that is single frequency sounds. Okay, we have a machine, well and good. So what? We deliver these sounds that are produced by the audiometer to the patient in a soundproof room, preferably where the noise is as least as possible. And then whenever the patient is able to hear, the patient responds to you and you mark all those observations on a chart paper. And that graphical recording of hearing of the patient is called as an audiogram. Audiometry is the test and audiogram is the recording. The graphical recording on a chart paper is called as audiogram. An audiometer is the device. These are the various terms. So in an audiometer, the intensity of sound can be increased or decreased in 5 decibel steps. Suppose it produces a sound at 30 decibels. Next, you can go either to 25 or to 35, not in between. The minimum interval is 5 decibels. So, it increases or decreases intensity by 5 decibels. Okay. And with this pure tone audiometry, we can identify the type, degree and configuration of the hearing loss. We will get a complete picture in a single piece of paper after plotting the audiogram. You can identify which ear, what type of hearing loss, whether it is conductive or sensorineural, there is defect in air conduction or bone conduction, and how much is the hearing loss, mild hearing loss, moderate hearing loss or severe, profound. You can get all these details by looking at the audiogram of the patient. So, in this we check both air conduction as well as bone conduction. So to assess air conduction, we use frequencies of 250, 500, 1000, 2000, 4000 and finally 8000. Next, to check for bone conduction, we start from 250 and same 500, 1000, 2000 and 4000 Hertz. We stop at 4000 Hertz. Normally for speech threshold, we check from 500 to 2000 Hertz. Normal hearing threshold is anything between 20 to 20,000 Hertz. But we only check for 500 to 2000, which is the usual speech threshold. So there is something called as pure tone average. What is pure tone average? It is average of air conduction thresholds of 500, 1000 and 2000. We are checking for various levels, but we select 500, 1000 and 2000 and take an average of them, and that is called as pure tone average, and that is very much useful. It is used to predict speech reception threshold and it is used for various other purposes. So what is pure tone average? It is the average of air conduction thresholds at 500, 1000 and 2000 Hertz. This is pure tone average. So, when we are checking for bone conduction, what we are actually measuring is the cochlear function. Yes, in bone conduction, the sound is directly transmitted to the cochlea via the cranium, via the bones of the skull. There is no need for the conductive apparatus. So while checking for bone conduction, we are directly looking at the cochlear function. And then when we are looking at air conduction, it gives us a comprehensive outlook of the conductive apparatus plus the cochlear function. Now how to find out conductive hearing loss? Sensorineural hearing loss is by bone conduction. In air conduction, when you measure, it is the conductive apparatus plus the cochlear function. Complete sum we are getting. So the difference between air conduction and bone conduction is called as air-bone gap. The gap between air conduction and bone conduction. And this air-bone gap, the difference between air conduction and bone conduction, gives us a measurement of conductive hearing loss. Conductive hearing loss. This is the interpretation of pure tone audiometry. With this background, let us look at how a pure tone audiometry is performed. This is the basic understanding. What is a pure tone audiometry? How sound impulses are produced by the audiometer and what exactly are we looking for? Now let us see the exact procedure. What is done in a pure tone audiometry? The method. How it is performed. So as I said earlier, we would select a soundproof room. And then we connect the patient to the audiometer. And first we check for air conduction and then for bone conduction. Both of them are separately recorded. The audiometer produces pure tones. And air conduction is checked via headphones. We connect headphones to the patient. And bone conduction is checked via a vibrator that is placed behind the ear at the mastoid. And that's how we check. Let me show a picture of how this entire setting looks like. So this is how it looks. In the first picture, you can see that both the examiner and the patient are sitting in the same room. And the examiner is using a machine, and that is the audiometer, and the patient is connected to headphones. And via the headphones, sounds are transmitted and the patient will respond. In the second picture, in this picture what you see is the patient is sitting in a soundproof box, and sometimes the patient and the examiner sit in separate rooms. The patient is in the soundproof room and the examiner sits outside, and separating both of them is a glass separation. A glass window or a glass piece is present so that the examiner can see the patient's responses. That's another way of doing it. So this is how the setting is. Here also the patient is connected to a headphones by which he receives the sound impulses. And after this procedure, what we do as an examiner is we chart all these on a graph paper called as audiogram. As I told earlier, it is a graphical representation of the patient's hearing. So let me show you how this picture looks like, how an audiogram looks like. So an audiogram would look something like this. On the bottom side you have frequencies 125, 250, 500, like that. There are various frequencies. And on the y-axis we have hearing loss from -10 up to 120. We are measuring the hearing loss and not the amount of hearing that the patient can have. It is the loss that he is having that is charted on this graph. So the audiogram makes two assumptions. One is the hearing of a normal person, both for air conduction and bone conduction, is at 0 decibels. That means there is absolutely no hearing loss. But in reality, it might not be 0. We will hear only when it is slightly more than 0. But for this purpose, 0 is considered to be the normal hearing level. No loss in the sense 0 decibels. And there is no air-bone gap. Normally, while we are performing tuning fork tests, especially in Rinne's, what we say is air conduction is better than bone conduction. But here in an audiogram, both air conduction and bone conduction are taken at the same level. There is no air-bone gap. Because if you show difference between air conduction and bone conduction, that implies conductive type of hearing loss. That air-bone gap is said to be the conductive type of hearing loss. So we plot both of them at the same level and we take that the hearing of a normal person is at 0. These two principles, what we do is we select various frequencies on the audiometer at various intensities and we keep on increasing the intensity, and at wherever the point the patient can hear, we mark all that on the audiogram and we use various symbols on this audiogram. Let us first understand what those symbols are before we put them on the chart. Symbols used in audiogram, they are different for the right ear and for the left ear. Now everything that is related to the right ear is plotted in red color. It is in red color. And about the left ear, it is in blue color. And while we are checking for air conduction, on the right ear, it is marked with circles. And while we are checking for bone conduction on the right ear, it is marked with this symbol. It is like an open bracket, a triangular open bracket. And on the left ear, air conduction is marked with crosses. And bone conduction is by this symbol. Now, while performing audiometry, there is a procedure called as masking. I will further explain why masking is done and how it is done. But if masking is done, then we use a separate set of symbols. That is, for the right ear, instead of circle, we use a triangle to indicate that masking has been done. And for bone conduction, we use this square type of open bracket. And for the left ear, instead of cross, we use a square, a box, and a square type of closed bracket. This indicates masking has been done. These symbols indicate masking has been done. If there is no masking, circle and triangular type of bracket in the right ear, and cross and closed type of triangular bracket in the left ear. If masking is done on the right side, triangle plus square type of open bracket. On the left ear, it is box with a closed type of square bracket. These are the symbols used. Now let me plot them on the audiogram so that you would completely understand. First I am checking for the right ear. First we check bone, repeat. First we check for air conduction and then for bone conduction. So the patient on the right side is having a hearing loss at 40 decibels on 250 Hz frequency. So I will mark a circle here. 40 decibels is his hearing loss. It is not the level at which he can hear, it is his hearing loss that you have found out by increasing the intensity of sound. Next, at 500 Hz frequency, it is at 30 decibels. And then at 1000, it is again at 40 decibels. At 2000, it is only 50 decibels. At 4000 also, it is at 50 decibels. So you mark these circles on the audiogram. Now let us plot the bone conduction graph. Say the patient at 250 Hz is having a hearing loss of 10 decibels. Now bone conduction is also plotted with red color because it is right ear only. It is plotted with this triangular type of open bracket. Here masking is not being done. At 500 frequency hertz also he is having 10 decibels loss only. At 1000 also say only that much loss. Until 4000 same. So bone conduction there is no fluctuation. At all frequencies he is having a loss of 10 decibels. Which is well within the normal range. 0 to 20 decibels we say normal. So we join all these. This is our bone conduction graph. Now between air conduction and bone conduction you observe some gap, isn't it? There is gap. This gap is called as air-bone gap. And this is a measure of conductive hearing loss. This is air-bone gap. Now this is just an arbitrary example. I have taken random figures just to make you understand how an audiogram looks like and how it is plotted. What is air conduction, what is bone conduction, what are the symbols that are plotted there, and how an air-bone gap looks like. Okay, so let us see the interpretations of an audiogram. Before we look at the interpretations, let us understand this concept called as masking. Now what you have to understand is, the sounds from one ear are transmitted to the other ear by transcranial transmission via the skull bones. The sound presented to this ear is perceived by the opposite side cochlea also. But there is a loss of 40 decibels in this transmission. So this ear say is having a hearing loss of 80 decibels. And this ear is having a hearing loss of 20 decibels. Now you presented a sound at 0, 10, 20, 30, 40. This ear cannot hear. 50, 60. Slowly what happens is, after 40 decibels, from 50 onwards, this ear will start to hear those sounds now. When this is at 10, this ear cannot hear anything because 40 is lost on the way. 20 also this ear cannot hear. 30 also this ear cannot hear. 40 also this ear cannot hear. Now this is having a loss of 20 decibels. So at 50, 10 decibels is transmitted to this ear but it cannot hear. 60 decibels when you present to the deaf ear, to this ear which is having 80 decibels loss. 40 is lost and 20 decibels is presented to this ear, and this ear starts to perceive that sound now. And the patient will falsely say, I am able to hear at 60 decibels of the right ear. Although right ear the hearing loss is 80 decibels, which you have found out by some other mechanism, at 60 itself the patient will say, I am able to hear. Why? Because the opposite side ear is responding to that sound. Or I'll give you another example. Say the left ear is having a hearing loss of 60 decibels and right ear no hearing loss. You gave a sound of 10 decibels, no transmission, 20 decibels, no transmission, 30, no transmission, 40 decibels, it has come. Now at 40 decibels, the patient will start perceiving the sound. At 50 decibels, this ear is hearing 10 decibels, so it will respond. At 60 decibels, this is hearing 20 decibels, so it will respond. Actual hearing loss of this ear is 60 decibels, but from 40 onwards, because of the opposite side transmission, the patient will say, I am able to hear, and you will start plotting it on the audiogram, which is false. It is a false result. So that graph that you are putting at 40, 50, 60 because of the opposite ear, it is called as shadow effect. It is giving you false values. Why? Because the non-test ear is interfering with the test ear's results. Non-test ear is receiving sound impulses and it is responding. So we do not want this to happen. We want to measure the hearing ability of both the ears separately. Yes? For that, what we do is, this non-test ear is responding to these sound impulses. We should not let it respond. Means we should not let it hear. How can we stop it from hearing? By diverting it, deviating it. How can we deviate this ear? By giving it some noise. And exactly this procedure is called as masking. So when you're checking for this ear, the opposite ear is given some noise, and exactly that noise is called as narrow band noise. Narrow band noise. It can also be given by a noise box called as Baronese noise box, or generally in a pure tone audiometry, that noise is given through the audiometer itself. The narrow band type of noise is given. So now the opposite non-test ear fails to catch these impulses given to the test ear. So we get the absolute results pertaining to the test ear only, without any unnecessary interference by the non-test ear. This procedure is called as masking. Now, should you do masking in all the patients? No, not necessary. Only when the difference of hearing in both the ears is more than 40 decibels. Only then you have to do masking for air conduction. 40 decibels is the number. When the difference in both of the ears is more than 40 decibels, then we have to do masking for air conduction. For bone conduction, always mask the non-test ear. I hope you have understood the concept of masking and shadow effect. The same concept is used in non-organic hearing loss also. Normally, when you do not mask, the patient should perceive sounds from the non-test ear and should be able to hear something, and you should be able to plot the shadow graph. But because the patient is malingering, he refuses to respond to that sound. Although he is able to hear some sound, he says, I am not able to hear anything. So you cannot see the shadow effect. This concept is also used to identify malingerers, the concept of shadow effect. Okay. Now let us see the interpretation of pure tone audiometry. Interpretation of pure tone audiometry results. In a normal person, first, a person with normal hearing, both air conduction and bone conduction are within the range of 0 to 20 decibels. In this graph, even if you plot somewhere here at 10 decibels, you shouldn't say the patient is having 10 decibels hearing loss. That is normal. Anything up to 20 is normal. 0 to 20 decibels is normal. Yes. Then next, in a patient with conductive hearing loss, what is the picture that we see on the audiogram? In conductive hearing loss, there is some problem with the conductive apparatus. Bone conduction is absolutely normal. Cochlea and the sensorineural component is normal. So, in conductive hearing loss, bone conduction graph is normal. Air conduction is seen at a lower level. And what you observe is air-bone gap. and that air-bone gap gives you the amount of conductive hearing loss. Okay? In a patient with sensorineural hearing loss, what happens is both air conduction and bone conduction are reduced. Because while we are measuring air conduction, we are checking the conductive apparatus plus the cochlear function. So, in sensorineural hearing loss, bone conduction is anyhow reduced. Air conduction measures bone conduction also. So, air conduction is also reduced. And this is seen more at higher frequencies. And conductive hearing loss, air conduction reduction is observed more in lower frequencies. In a patient with mixed type of hearing loss, both conduction defects are also present and sensorineural defects are also present. Then what happens? Again, here also both are reduced. But air conduction is much more reduced. So again you will see an air-bone gap. Air-bone gap is present. Both are reduced, but air conduction is more reduced than bone conduction. So air-bone gap is seen. This is the various types of charts that are observed on an audiogram. So audiogram has given you information about what type of hearing loss it is, whether it is conductive or sensorineural or mixed. I told you it also tells you about the severity of hearing loss. How do we assess the severity of hearing loss? Anything between 10 to 20 decibels is considered normal. You can say no hearing loss. Anything between 20 to 40 is considered to be mild hearing loss. 40 to 60 is moderate hearing loss. Anything between 60 to 80 is considered severe type of hearing loss. More than 80 decibels is considered to be profound hearing loss. Now an audiogram has given you exactly how much is the hearing loss, and you can use this table to interpret whether it is mild, moderate, severe or profound. So this is the information that an audiogram has given you. Now let us see the uses of pure tone audiometry. And with this, we can conclude this topic. So first and foremost, what is a PTA giving you? It gives information about the threshold of hearing by both air conduction and bone conduction. And based on that, you can obtain the degree and type of hearing loss. That is the primary and first purpose of a pure tone audiogram. So it measures the threshold of hearing by air and bone conduction. With this, you can get the degree and type of hearing loss. The second use is that it provides a record. Now this might not sound very important, but it is actually very important. You need a record. Oral statements do not hold any value. Suppose you are treating the patient or you are performing a surgery, you need a record of what is his hearing loss. To measure later on after the treatment, you can get the prognosis of your treatment, prognosis of the condition. It is used to follow up the patient. There are various purposes of having a record. Having a record is always important. Third, it can serve as an evidence in medico-legal cases. Suppose the patient wants to claim some benefit. He cannot go there and tell, my doctor has told that I have 70 decibels hearing loss. No, he needs to show the chart. He needs to show the pure tone audiometry result to claim his benefit. Or you have performed a surgery and the patient's hearing has slightly improved. But the patient says that no, my hearing has not improved even after the surgery and I want to sue the doctor. What is the proof that it has improved? A pure tone audiometry that has been done before the surgery and that which is done after the surgery, and if there is a difference in both of them, there is an improvement or no improvement, or in fact after your surgery it has been decreased, all this can be shown, can be proved by seeing the pure tone audiometry. So it's useful in medico-legal cases. It is also useful for prescribing hearing aids. If you want to prescribe hearing aids for somebody, how will you know at what sound intensity you have to prescribe? Based on the results of pure tone audiometry. Next, pure tone audiometry also predicts speech reception threshold. It is usually within the range of 10 decibels. So these are the various uses of pure tone audiometry. With this, I complete pure tone audiometry, and let us learn about further audiometric investigations in the next video. Thank you very much.